Hi, everyone. We can give everyone a couple minutes because I know that we'll have a few more attendees at least, and they're still steadily streaming in. Okay. Welcome everybody to today's MGB Neurology Grand Rounds. My name is Alex Jeffrey. I'm a PGY4 child neurology resident here at MGH. We had people joining virtually only today. If you have questions during the lecture, please direct them to me in the Q&A portion of your Zoom. It is my honor to introduce our speaker, Dr. Sonika Agarwal, an assistant professor of clinical neurology at the University of Pennsylvania School of Medicine. Within child neurology, she is an expert in fetal neonatal neurology. Her background gives her unique insight into the field with over a decade of OB-GYN training, specializing in high-risk OB and maternal-fetal medicine prior to her training in child neurology. She has many years of clinical, academic, and research experience at India's preeminent tertiary care centers, the All India Institute of Medical Sciences in Delhi and the Institute of Medical Sciences, BHU, in addition to Baylor College of Medicine and University of Pennsylvania, where she currently practices. She has authored many peer-reviewed publications and has been recognized for her work. Dr. Agarwal has a special interest in education and loves to mentor medical students, residents, and fellows, and has been awarded several education awards. 2020 Top Neurology Faculty Teaching Award, 2020 American Academy of Neurology A.B. Baker Teacher Recognition Award, 2018 Jefferson Neurology Faculty Teaching Award, to name a few. She is also the recipient of the 2016 CNS Outstanding Junior Member Award for her work on the Fetal Neurology Registry at Texas Children's/Baylor College of Medicine in Houston. Dr. Agarwal serves on the board of directors at the Child Neurology Foundation as director of resident fellow board and associate editor of the Fetal Neonatal Neurology section of the Journal of Child Neurology Open, the editorial board of pediatric neurology, and is on the steering committee of the Global Pregnancy Collaborative. Her leadership work in the AAN 2021 Transforming Leadership Program led to the development of the Fetal Neurology Consortium and subsequently the Fetal Neurology Special Interest Group for facilitating collaborations among fetal neurology programs across the U.S. for research and educational initiatives. She has also developed a series of podcasts on fetal neonatal neurology within the Journal of Child Neurology/CNO. Dr. Agarwal has participated in the AAN Neurology on the Hill program and serves on national committees at Child Neurology Society and AAN. Most recently, Dr. Agarwal has been elected the vice chair of the AAN Child Neurology section. I was fortunate enough to have the opportunity to do an away rotation with Dr. Agarwal at CHOP in 2021. I was awed and inspired by her as a clinician, educator, and leader. She expertly balanced these roles during even the most emotional and challenging fetal and neonatal cases, and I learned so much from her. Her many awards and education are much deserved. I also had so much fun, and I'm so excited to hear her grand rounds today. Thank you, Dr. Agarwal, for speaking with us today.
Thank you, Alex, and thanks everyone for inviting me. That was a wonderful introduction. So I will give an overview of fetal neurology and what the field and practice looks like currently, and how we see the field evolving. And I'll give an overview of some of the commonly seen diagnoses and what were the challenges in the counseling, and how the outcomes shape the trajectory over the time. Also, we'll bring in some global experience as was requested to add in from the MFM time, and then present some work of the Fetal Consortium. So about 2 decades ago, the field was mainly focused on neonatal assessment of children, pediatric neurological disorders. And if you see this global burden of disease for DALYs is the disability adjusted life years. If we see in the neonatal period, this green on the graph, it has a high as 40%, which is probably related to prematurity and neonatal encephalopathy from various causes. And over the years, as the pediatric to adult years evolved, the burden of neurological diseases is around 10 to 15%. So the neonatal period, and a lot originating from the fetal period, is really a very intense focus period where neurological disorders present at a high prevalence with various conditions. Now, if you look at the whole field of fetal and neonatal neurology, slowly our assessments are moving from the newborn, and neonatal assessment is very important. And when we examine the baby and we get a full physical clinical exam, that is obviously completing our diagnosis as we follow them through the years. However, this field of fetal neurology, focusing on maternal fetal medicine and how it integrates with the placental condition, fetal triad, are all important and are evolving over the years and adding more to the field of fetal neurology. Now, fetal neurology starts with the assessment, usually the level 2 anatomy scan, which is an ultrasound. They get referred if there's an abnormality. Common abnormalities, I'll present some cases. It could be ventriculomegaly, midline abnormalities. And then they get referred for a fetal MRI, which then leads to a fetal neurology consult. And we look at the infectious testing, genetic testing. Genetic testing is also evolving. It started out with karyotype, FISH, chromosomal microarray or SNP array or gene panels, and now is moving more and more towards whole exome. So some of the studies you see on the right have looked at the utility of whole exome. Meridian study was the big one for looking at the comparison with the ultrasound and fetal MRI. And then the comprehensive consultation happens in the prenatal period. We try to do combined consultations with the MFM, especially when the discussion is really complicated and we think decision-making is involved. And the baby is then followed for the biophysical and serial ultrasound monitoring. And as other consultations may get involved also during the prenatal period. And then comes the period of the postnatal assessment with imaging and other testing, and long-term follow-up with involvement of early intervention programs. So if you look at the fetal anomaly diagnosis, ultrasound evolved in the 1950s, followed by the genetic testing, amniocentesis, chorion villus sampling in the 1960s and 70s. Real-time ultrasound came in back in the 1970s, followed by triple screen, quad screen, FISH testing, and then 3D ultrasounds. And fetal MRI actually started more in the late 90s to 2000s, when the American College of Radiology approved that this was safe to be done in pregnancy. And over the last few, maybe 5 years or so, the exome sequencing in prenatal period is really evolving, although exome was mainly focused on the neonatal, postnatal testing earlier on. So whenever we see these patients, the questions that we are faced is what kind of prenatal surveillance is needed, who needs a fetal MRI or not. So based on the fetal ultrasound, the MFM and the referring OBs make that decision. As fetal neurologists, we usually get involved after a fetal MRI is done and it shows an abnormality. Many patients will be followed serially in the pregnancy, if say for ventriculomegaly or any other hemorrhage for any serial progression. And then amniocentesis is also offered to some patients. Some may agree, some may not. Infectious testing, genetic testing, all these are important tests to be done in the prenatal period and discussed at the consult. In the consultation, we take into view all the testing and how we approach the diagnostic and prognostic counseling. It depends on that. And we also discuss about planning the timing of delivery, the location of delivery, whether they can deliver locally versus they need to deliver at a specialized tertiary care with a higher neonatal intensive care support. So that sometimes is a dynamic decision-making that evolves in pregnancy. And then the pregnancy, the fetus is monitored with the ultrasound, biophysical monitoring, fetal movements, and the frequency may vary. Postnatally, again, the postnatal MRI is important. 3T MRIs are being done as more and more frequently now, and then genetic testing, if not done in the prenatal period, is usually then done in the postnatal period, and then neurology follow-up, other specialty follow-up, and early intervention programs. So now discussing some common diagnoses that we see in the prenatal period and how these evolve. So this was severe ventriculomegaly who had aqueductal stenosis. On the top, you see the fetal MRI. There's a little cortical breakthrough. This is the postnatal neonatal MRI. This child ended up having a shunt. Genetic testing did not show anything positive. She also had some other anomalies. Has had a single seizure due to shunt malfunction. Shunt was pretty early, day of life 30, and has had one revision. Usually revisions are more common in the first year. And this child at 4 years, despite the severe hydrocephalus and did not have any cortical malformation. So that is one limitation in an early pregnancy fetal MRI. We always do mention that we are very early in pregnancy and the cortical development and maturation is still not complete. And that can sometimes be clear after the shunt or after when the postnatal MRI is done. This child is, however, doing much better than we thought she would do and is advanced in the developmental skills and is cognitively very intact. Now, looking at some other examples, this is another example of aqueductal stenosis. Here, the genetic testing was done, was negative. So usually with a boy, we will do the L1 CAM panel or the hydrocephalus panel in the prenatal period. If the family agrees for amniocentesis, this is again showing the huge ventricles. And ventriculomegaly more than 15 millimeter is 90% of those children will have some neurodevelopmental deficits and will require early intervention. And then this is the postnatal scan. This is the neonatal in the middle. And on the right, you see the MRI that was done, had another MRI at 1 year and then 2 years, and actually did not need shunt. And even though prenatally we were thinking the aqueductal stenosis, we did counsel about shunt and risk for developmental delay. However, this child, as the brain grew and the space grew, there was opening and did not end up needing shunt. So counseling for ventriculomegaly really depends on the degree of ventriculomegaly, any associated anomalies, cortical malformations, associated genetic syndrome, whether there's an infection and other injury to the other parenchymal areas, white matter, and then progression over time. So these are all factors which only become clear as the pregnancy advances. Now, this is another patient who had started out as mild ventriculomegaly. So this was a late referral. The ventriculomegaly was noted in the early, in about third trimester. So she was almost like 34 or 35 weeks. And there was these little septations which were thought to be probably possible we counsel for risk for CMV versus it was a small choroid plexus cyst, and we discussed that the postnatal MRI will be more helpful in the diagnosis. Now this child, when the baby was born, there was some increased mineralization and prominent vessels in the white matter. There was mild inferior Wormian hypoplasia, and there was ventriculomegaly with septations in the posterior horns. And the baby actually had signs of active CMV infection with petechiae and mild hepatomegaly, which was only clear by a postnatal exam. And so she was enrolled and she was treated with valganciclovir for 6 months, underwent intensive therapies, physical, speech, occupational, vestibular. She really had lots of balance issues and ataxic gait, hearing loss, had a hearing aid in 1 year, and now at age 4 years almost, the other ear also had some minimal hearing loss, and so she's getting a hearing aid in that ear. And but cognitively she's very smart, and she does have balance and coordination issues, hyperactivity, and maybe get a learning disability or other things may surface in the later years. But she walked late and she's fully conversational and continuing to make good progress. Now, bringing in the consult where we are seeing a pregnant patient with severe ventriculomegaly, aqueductal stenosis early on in pregnancy, how difficult decision-making and how neonatology, palliative care, how our decisions can change over time. Now, this is these are 2 scans. So this is a fetal MRI, and I'm discussing 2 patients side by side. Both had similar pictures. And this was the neonatal MRI with huge distension of the ventricles with obstructed aqueductal stenosis. The first baby underwent a amniocentesis, had a diagnosis of L1 CAM, and had a VP shunt placement in the sorry for the typo. This is the slide I added yesterday that I was talking to Alex about. So had NICU stay for 3 months, and then 4 months age had a cardiorespiratory arrest at home, went home and was on NG tube feeding and some oxygen support, and there was a unexplained cardiorespiratory arrest, possibly worsening hydrocephalus, was taken to the ED, and the baby passed away. So this genetic diagnosis obviously is associated with a poor neurodevelopmental profile with intellectual disability and other issues that can be associated with a more like a spastic quadriplegic cerebral palsy-like picture. Now, patient 2 had a similar MRI. This family had, I saw them very late, around 36 weeks. It was a late referral, and they had 4 healthy children. The family requested palliative care involvement when we brought it up, and parents agreed to approach with comfort care approach and not do any other testing, looking at the profound adverse neurodevelopmental outcome that could be expected for this child. However, they ended up going into, I think, borderline preterm labor. The baby was resuscitated, put on a ventilator for 1 week, and despite the request for comfort care, the discussion around the time of delivery somehow led to the baby being on a ventilator, and then they were transferred in the 2nd week for second opinion. And the baby was ventilated on trach and G-tube. I think was admitted to the NICU at our hospital for over 3-4 months, and finally went to foster care and is probably at a long-term care facility. And so this was a very challenging case where the family clearly expressed their wishes. However, our counseling around the time of labor and delivery is very important. So a combined consult with palliative team, neonatology, meeting prenatally and making a plan for palliative delivery is also very important to honor the family's wishes when a profoundly impaired neurodevelopmental outcome is predicted. So looking at hydrocephalus management in the global setting. Now, costs of the, whenever we are counseling a family, so whether you are counseling here in the US versus in another country, be it Africa, be it India, be it anywhere else, Malaysia. So it really depends on the regional support system, the outcomes, the surgical procedures, the shunts, what is available in that area. And the counseling really needs to be tailored to that. So in India, this was a study that I pulled up where there's several innovative shunt systems that were designed because the shunts from abroad were really expensive, and all these shunts, Upadhyaya shunt, Chabra shunt, Sri Chitra shunt, they've all been tried in various other countries and showed comparative outcomes based to other more expensive shunts from US or any other country. So these shunts have been widely used, and this study was done with almost 200 children, and they found good comparative outcomes. However, look at the process of cephalocentesis. So if I look, obviously this is not a procedure that is done commonly. And I was surprised that I even found an article when I searched over the last couple of weeks. This was a 2001 article, because I do remember when I was a fellow and attending in India, I remember patients where they came fully dilated, no prenatal care, hydrocephalus. There's no guarantee that they will ever come back for prenatal care again. And we want to avoid a cesarean section, and we know the baby will not survive. So cephalocentesis is offered in those kinds of patients where the fetal outcome is definitely not going to be positive, and the family wants palliative decision making. So that's a procedure. And this is a recent study where cephalocentesis was actually done transabdominally. But what I have remember from earlier on is we used to do it in those cases which came where we know if we were to do a C-section, they would next time probably come back with a ruptured uterus and even endanger the life of the mom. Now, in this article from US, the authors from Houston and New York, two centers, published 3 cases with hydrocephalus and holoprosencephaly, where palliative decision-making was discussed with the family, and they opted to do a cephalocentesis. So the role of cephalocentesis is obviously a big ethical discussion with palliative team, with neonatology, with neurology, MFM, everybody present. And if the family does want a perinatal palliative care approach, we should do a thorough discussion and plan these deliveries accordingly. So it's a shared decision-making model, which is obviously very challenging and may need more than one meeting. Now, moving on to prenatal intraventricular hemorrhage. So this is another common consult we see. It could be due to multiple causes. They could be just the germinal matrix hemorrhage versus they could be other non-genetic causes or genetic causes such as collagen mutations. We are increasingly seeing and diagnosing more of the collagen COL4A1 and 2. And the other causes could be just the neonatal or fetal NATE, or what we call neonatal alloimmune thrombocytopenia. Exposures to drugs, to toxins, to medications have also been implicated in intraventricular hemorrhage. Now, this is started out as hemorrhage on one side with expansion of the ventricle on that side. The baby ended up having a shunt in the first week of life. Had a cerebral small vessel disease panel that was negative, and walked around 17 months, talks in 3-word phrases at 24 months, had a couple EEGs for staring spells, but no seizures so far. And we continue to monitor their developmental progress. Now, looking at the challenging part of counseling for prenatal IVH, you can see the variability in the outcomes. So pretty similar scan, started with hemorrhage on one side, expansion of the ventricle on one side. This child had a very typical motor development, and but had profound speech and language delay. So it really matters where, what tracks white matter, how early in development versus late, that the brain parenchyma gets injured, that interrupts the development. And this child has a diagnosis of autism spectrum, is nonverbal, has pretty significant behavioral issues, and is in ABA and other therapies. However, another prenatal IVH with such a huge expansion of the ventricle got a shunt early on in pregnancy. This one did not require a shunt, the one on the left. And this one also walked at 16 months, has a normal speech development, and one seizure with fever. So the variability in the spectrum of the outcomes is really discussed during these consults, bringing up the limitations of our prenatal testing and prognostic process. So long-term outcomes with ventriculomegaly and hydrocephalus, approximately 40 to 50% will have normal intelligence. Seizures and epilepsy risk is high. Overall mortality rate is 5%. Shunt failures are maximum in the first year. And on an average, shunts are revised 2 times in the first 10 years. The risk of intellectual disability, especially with the genetic mutation, L1 CAM or others, is approximately 35% more for the genetic cases, or with more injury to the brain. However, with rehabilitation supports and early intervention and special education programs, these children are leading full and may lead close to normal lives, of course, with more of the seizure management, more neurology visits, and shunt requiring attention. Col4A mutations, again, there is a spectrum to these. In the first few years of being a CHOP, I really saw some very severe, profoundly impaired outcomes with Col4A. However, in the last couple of years, we've had very focal injuries on one side, more limited to just the MCA area. And these are non-vascular hemorrhages that happen. They are not due to any vascular territory. They are due to the gene mutation that causes the vessel fragility and causes it to bleed. Now, this child had worsening ventriculomegaly, born at 36 weeks, had seizures at birth, required phenobarbital, but family preferred to wean it and then wait for another seizure to go back on medication. Got a VP shunt at 4 months of age, has has moderate global developmental delay, is enrolled in therapies. One of the optic discs is also atrophied and is continuing to follow with various specialties. However, this is another case with the prenatal injury with hemorrhage and cystic encephalomalacia, or the porencephaly, what we call, with multiple other hemorrhages you see in the susceptibility image. This is the postnatal image, including cerebellar injury. So cerebellar hemorrhages here on the right, and multiple white matter hemorrhages with one big cystic encephalomalacia or porencephalic cyst. This child had spastic quadriplegic cerebral palsy, profoundly delayed, nonverbal, non-ambulatory, also had, as she grew older, Raynaud's disease and temperature instability, really poor tolerance to even going in the swimming pool was not possible, had intractable epilepsy, finally went on hospice care, and then passed away at 22 months. Now, this is another recent fetal consult that they have a history of an ectopic, one healthy 2-year-old. Mom had COVID infection at 14 weeks gestation, and then presented with this one big porencephalic on the left MCA area. But there was also this other side where early lesion was visible. So with one-sided lesion, you would counsel more for the hemiparetic cerebral palsy, but with the unpredictability with the hemorrhages is, as you saw in the couple prior cases, it starts out on one side, and how the other side is going to evolve over time can only be clear as we follow on serial ultrasounds. So this, again, we requested Col4A testing, which is pending, and you can see the hemorrhages starting in non-vascular territories on both sides. Now, Prenatal cystic encephalomalacia and AVMs can also sometimes be noted. This was a very prominent finding on the MRI that I wanted to include. This was again a late referral. On ultrasound, there was cystic encephalomalacia and baby got referred for fetal MRI, and you can see in the temporal lobe, there is this cluster of arteriovenous malformation, which was thought to be that the cystic encephalomalacia probably evolved from multiple hemorrhages from this. And when we took the family history, there was multiple members with HHT and who had been tested genetically positive. Cerebral AVMs are reported in as many as 10%. Mom had history of nosebleeds and was tested postnatally and was found to be the positive, and this baby also tested positive in the gene. Baby surprisingly did not need any support in the NICU period and has gone home, and the family also opted to have one embolization procedure done for this baby and is being followed in our vascular anomalies clinic. Now, coming to other midline anomalies, septo-optic dysplasia and absent septum. So whenever there is absent septum, families get referred for fetal MRI, mainly to evaluate the prosencephalon and whether there's any cortical fusion, or for septo-optic dysplasia. Now, septo-optic dysplasia, again, is a heterogeneous condition with variability in neurodevelopmental outcomes. Learning disability, seizures, intellectual disability, vision problems, hormonal problems, all have been reported. Not all children may have all three findings. Looking at this child who had absent septum and left optic nerve hypoplasia, the postnatal exam actually found the optic nerves normal, and clinically functional vision is normal so far. He's now 3.5 years old. The panel for the 4 genes was negative. He also was born at 31 weeks, so was premature and stayed in the NICU for about 2 months. And he walked, motor development was good. He has mild hypotonia, but otherwise walked at 15 months. And while his social, pragmatic language and interaction and expression is not typical, he's at 3.5 years, he's speaking in sentences. Yesterday in the clinic visit, any sentence that I would ask him to write, he could write it. He had a little slate with him. He's really focused on reading and writing, and he can identify numbers, letters, spellings, write sentences, reads at grade 1 level. I handed him a book and he just finished the whole book while we were doing the visit. And but his social interaction, back and forth, reciprocal conversation, he has been given a diagnosis of autism by the developmental visit testing, and we are continuing to follow him, but he's really gifted in the cognitive skills. And then coming to agenesis of corpus callosum. So this is also one of our common diagnoses that we see. And it's a heterogeneous condition. And whenever we discuss whether it is isolated versus non-isolated. Sorry. And if there is associated cortical anomalies, then we usually will discuss that the risk of neurodevelopmental delay and seizures is higher. So sometimes we also have seen teenage patients who present with headaches, and they get an MRI and they'll be colpocephaly and ACC. I've had a couple headache patients who were found at later age. So these kids could go through school with mild learning disability and ADHD-like symptoms and do relatively well. Now, this picture on the right is actually a functional connectivity study where they found, this is a smaller study which has explored, they found that the intrahemispheric connections were increased in where the corpus callosum was missing. And that's probably looking at why these kids are actually doing better than with such a big part of the connecting nerve fibers with right and left of hemispheres missing. So there's this recent study from Australia where they actually interviewed. So we, as far as child neurologists, we look at outcomes early on, and we try to follow them through their early school years. Now, this study is very interesting. They interviewed face-to-face 8 adults aged 23 to 72 years to explore their lived experiences. And this is one of its kind studies from Australia, and they found several challenges that these individuals, because their disability was not visible, they went through their school systems because they were walking, talking, interacting, but they had challenges with education, with social inclusion, identification as adults, being able to express what their needs are. And they brought out this thematic map, how to guide clinicians, researchers, the adult physicians who follow them, how to integrate them better as far as societal inclusion, education in the school, job and vocational employment, and community supports. So this is a very interesting study for those who are interested in looking at adult outcomes for kids with these disorders. Now, the challenges with ACC, with this patient that I saw, we saw them early in pregnancy, 21 weeks. It was an isolated ACC. They presented again for ultrasound with worsening colpocephaly at around 28 to 36 weeks serial ultrasound. And repeat MRI was not done. However, with worsening colpocephaly, we did counsel that there could be other cortical malformations which could only be clear on postnatal MRI. And this baby on postnatal scan had what we call subcortical band heterotopia, missing ACC here, and you see the subcortical band heterotopia of the double cortex syndrome with the DCX gene, which predisposes you to seizures and intellectual disability, behavioral disorders, learning issues, all can be seen. Now, complex brain malformation, these are pictures of 2 siblings. These are, you can see the big posterior cyst, partial fusion. This is the brother who's now 4 years old, profoundly delayed, walks with a walker, few steps, and is G-tube fed, has had a single seizure. And this is the younger sibling with an identical brain malformation. However, whole exome, trio whole exome has been negative, and we have not been able to identify a cause. Now, with complex brain malformation, the perinatal palliative care and shared decision-making is also very important. Now, this is another example of how our decision-making can really change and evolve from pregnancy through postnatal period. And this was a patient, prenatal consult, seen for severe ventriculomegaly, absent corpus callosum. The brainstem was really deformed. There was initial suspicion whether this is Walker-Warburg with lissencephaly, and then postnatally similar findings were confirmed. The brainstem was really thinned out, the cerebellum and vermis was absent, the brain was smooth, lissencephaly, and huge expansion of the ventricles. Now, prenatally, there was a plan for comfort care approach. When the baby was born, the baby was supported and parents were at bedside. However, the baby started having apneas. And for apneas, the NICU team initially supported the baby with oxygen, some CPAP later on, and then EEG was connected. And when the EEG was connected, those apneas were seizures, and the baby was found to be having continuous subclinical seizures. So for about 36 hours after the discussion with the team, we escalated, the parents then said, let's manage the status and see, but we really don't want him intubated because we want to go home soon and have as much time as we can with the baby, because they thought the baby will probably pass away maybe in a month or a few weeks. Nobody can predict that, but apart from the apnea, there was no other, the baby was just profoundly hypotonic. So we start our seizure pathway, the status pathway, the baby gets on MIDAS. We are not able to treat this subclinical status. Then we decide to go on Topamax. with a more chronic approach towards the epilepsy, that this is a brain malformation with epilepsy, and we de-escalate the status pathway, and because family really wants to go home. And finally, the baby is able to go home in a week. The baby was tested positive for the genetic testing, came back positive for the tubulin, the TUBA1A mutation, which is a tubulinopathy and known reported with similar brain malformations. And finally, when the baby went home, the apneas had resolved. He was needing oxygen as needed, feeding by tube. And then family expressed wishes for adding more seizure medications. So the decision is really involving, and this baby is now 14 months old and is on 4 medications for seizures. So it's always a shared decision making. Parents can sometimes choose to treat at birth. And so a very close connection and repeated discussion with the family to support and honor their wishes is important to help them through these challenging decisions. Now, some of the other anomalies we see are Dandy-Walker malformations, which are, again, some can be genetic or non-genetic. This is, again, MRI with the classic Dandy-Walker, absent Borvis and cerebellum with a big posterior fossa cyst. The baby needed a shunt early on. And these are actually 2 siblings. So one of them, they both have the chromosome 6p deletion syndrome, and one has cisterna magna and has a shunt and profound delay, whereas the other one has Dandy-Walker. Fetal MRI is also important to diagnose any abnormalities in twin pregnancy. Twins can sometimes have hemorrhagic strokes, hypoxic ischemic injury. They can have porencephaly, cystic encephalomalacia, any other ischemic lesions. This was a twin pregnancy where one of the babies had bilateral MCA area hemorrhagic strokes and underwent genetic testing also, which was negative and is being followed through the developmental, neurology, and early intervention programs. Now, obviously, as you see with these cases, the fetal neonatal neurology, every time at each step, we have more questions when we do a test, but we don't always have a clear answer because it's the long-term trajectory that is important for these babies to be followed. And families have numerous questions, but they also in that moment want some hope and how to empower them to address their psychosocial stress and screening. All that is very important during these consults and through the postnatal period, because care for these infants is obviously challenging for the families. Now, looking at the variability in the fetal neurology practice, as Alex introduced, when I was enrolled in the AEN leadership program, I had to do a project on where I could use the skills that were taught in that program. So I thought, like, why not create a fetal network for collaborations for education, for clinical practice. We don't have any guidelines. And then also, just like outcome studies or natural history studies, how do we bring a group together? So this is the members of the consortium, and we the first study we did is to understand the practice of fetal neurology. So all the institutions, the survey was sent out through the child neurology communication website, and some centers have not responded. Doesn't mean that they don't do fetal consults. So these are the centers around the country that responded. And you can look at the variability in the responses. So to the question of what is the earlier gestation fetal MRI is done, it starts right from 16 to 17 weeks and some late referrals. But the majority are doing it in the 19 to 22 weeks. Now, 16 to 19 weeks, 20 weeks is very early. The posterior fossa, corpus callosum, all these are still maturing and forming. So many times we don't get a proper picture, and then we say, let's repeat an MRI after 2 weeks. So the ideal period that has been recommended is after 19 to 20 weeks Obviously, with the recent changes in the legal limit for termination and the law around it, makes it challenging for MFMs and OBs and us fetal neurologists who are involved in these consults. So looking at the common diagnosis, ventricular megaly is by far, midline anomalies, agenesis of corpus callosum, absent septum, then the posterior fossa malformations, which is the Dandy-Walker spectrum, and then the complex malformations, holoprosencephaly, cortical anomalies, and spinal and microcephaly. Some non-CNS consultations also, neurologists get involved. Sometimes they may be an IUGR and you have a smaller head size, or you have an IUGR with a little bleed, or you have an IUGR with an immature brain, or cardiac babies. They can sometimes present with signal changes, hemorrhages, for which we can get consulted. And then babies with CDX, sometimes you'll see, or with genetic and syndromic diagnosis, we can sometimes be involved with based on any associated brain anomalies. Now, looking at the genetic counseling part, so not all centers will have a support or availability of a multidisciplinary consult with a fetal neurologist or a child neurologist with MFM and genetic counselor. However, genetic counseling is recommended and is almost mandatory for any fetal consult, if obviously it is available. So if it's not at one center, they would probably get them connected elsewhere for a genetic consult. Now, trainee involvement. So education is so important. Not all our trainees are getting the experience. At CHOP, we have created a fetal neonatal elective where they will rotate for a few weeks. But some who are really interested will join us for as many fetal consults as they can. And that's what I did in my training at Baylor. I would just go for any fetal consult that was there in the last 2 years, just time permitting, go and see as many as you can, because whether a center has a fetal center or not, fetal consults are being, child neurologists are increasingly being asked to do these fetal consults because an abnormal ultrasound is leading to a fetal MRI, and then comes the child neurologist's involvement to counsel the family about the possible outcomes. So the trainee, there's a big gap in the trainee education. So that's one thing that we need to develop. Then prenatal testing, obviously, again, it's a patchy response. Some are discussing, some are not. Whole exome is being increasingly used. And then postnatal follow-up is also very heterogeneous. Some will do, the majority will get a fetal MRI. Majority who have an abnormality on fetal MRI will get a postnatal MRI. However, sometimes asymmetric mild ventricular megaly almost resolved, or there's no other, there was a little signal, but the ultrasound is normal. So some will get away with an ultrasound and then continue to follow clinically. If there is delay, then you could go back and do the MRI, but majority will get a postnatal MRI. Now, most centers are doing developmental interviews like we do with the history when we see the patient. And then ages and stages questionnaire is a popular second choice. And then formal developmental testing is less common. So unless there's a multidisciplinary program following these children, the formal developmental testing becomes challenging. And then we sent out, one of the questions was areas of interest that people would like to discuss. So clinical guidelines, outcomes, practical training, fetal neuroimaging. So learning reading the MRI along with the fetal radiologist, and also building our skills to counsel these families, looking at the scans ourselves. That's also very important. Now, so this paper is going to be out soon. It has been accepted. So for those who are interested, and then this is a topical review we recently wrote for discussing, we gave a spectrum of a variety of cases in commonly seen, and how the challenging process of fetal neurology consultation, prognostic counseling, what are the limitations, and how sometimes you see, as with those palliative cases, how the decision making is really dynamic. We set out for comfort care at week 36, doesn't translate into comfort care. The baby is 14 months old and is on 4 medications. So really a shared decision-making approach with the parents is very important. And while currently the care is really expert-based or center-based, collaborations need to be established. So that's the goal we are working on with the consortium, how to plan more evidence-based studies, how to have large-scale outcomes data studies or natural history studies for various conditions. Because if you go and look for septo-optic dysplasia, oh, there's this paper with 10 studies, 10 patients, or you look for cerebral hemorrhages, there's a paper with 8 patients. So how do we discuss outcomes effectively and more with a more well-informed approach? And then, of course, the curriculum development and training and the guideline development is a big goal. So this is a recent paper that was published by the ethics committee of the Child Neurology Society with Dr. William Graff and others. And they have discussed this, how the fetal to postnatal transition and what emerges at what gestation, and how medical termination of pregnancy is obviously a very difficult decision-making for parents with the current change in laws. And so this paper, for those who are interested, it's a very good review that has been recently published. And obviously, with any complex brain malformation where the neurological outcome could be profoundly impaired, the option of termination has to be discussed, and antenatal palliative care has to be brought in. When do we protect the mom's health over the fetal outcome? So all these are really complex ethical decisions, and which require more and more conversations and support for reproductive health and fetal and neonatal health and outcomes. And so fetal neurology combined with neonatal neurology is really very key for early diagnosis, early planning of the perinatal and postnatal period, and changes and early attention to problems of early origin neurological disorders can really change the burden of neurological disease, the morbidity and mortality, or the brain health across lifespan. So really that's a program that is also very aligned with the WHO goals, the sustainable, even for other countries where this field is really picking up a lot more interest, especially with the fetal and neonatal programs to improve the outcomes. So this is just a picture of all the places, starting from my school in India to the medical school to the All India Institute of Medical Sciences in Delhi, picture of Baylor and Texas Children's where I trained, and then I'm currently at CHOP. I briefly worked at Jefferson also. So that's all, and I think I'll stop share so we can answer some questions.
Thank you very much for an excellent talk. Dr. Florence Lai has had her hand up for a lot of it, so I will unmute her so that she can ask her question. Dr. Lai? Anybody else have questions while we're waiting for Dr. Lai? I have a question. How often do you see the decision for comfort care to evolve after birth and throughout the lifespan? Did you share cases that were unique examples, or is this quite common?
So the comfort care cases will come in once in a while. They're not very common. So obviously the training and discussion around it is a learning for all of us, right? And what we discuss at 36 weeks, like I said, it may evolve and change because then the family opted to treat the status, right? So how do you send the baby with apneas home? So really, but you also have to honor what they really wanted to get home with the baby and get maximum time, because they didn't expect, they thought the baby will pass away soon. So obviously that it was like a multiple discussions daily with the family of keeping them updated with each step in the decision-making process was important. Yeah, but those are not commonly seen discussions or cases, but palliative, most big programs may have palliative care teams where you think a baby may not do well soon after birth and may need life supports. You can give that option of involving palliative care, so they get to know the family, and then the discussion in the postnatal period is always easier because they already know each other.
That makes sense. Thank you.
Sorry, can you hear me now?
Yes.
Yes.
Oh, I'm so sorry. I was trying to find the unmute button. Anyway, so my question is, I have a number of individuals who have learning disorders, and when we do the neuropsychological testing, sometimes they have a very wide difference between right hemisphere and left hemisphere. However, some of them they seem to be of quote unquote normal intelligence in some ways. Many times they have right hemispheric issues. And I've always been, I wanted to know what the experience has been for other people. My question is whether or not to do an MRI to look for abnormalities and how that would affect the child and maybe the family, emotionally and socially. Have you had an experience with that?
Yeah, so for cases like, the agenesis of corpus callosum, there's several studies with the neuropsych, and that these kids may not show visible differences.
Yes.
But with higher functioning studies, they show differences. And some of the little ones that I'm following, I'm seeing for the last few years, they establish early handedness. So they tend to use one side more than the other. So that's also I'm seeing with the ACC kids, which I'm not sure I've read it anywhere in the literature, because they probably the brains are not integrated. So, I mean, if you are seeing significant issues and learning disability, the option of MRI could, I would say, be discussed with the family every once in a while. We all have consults of learning issues in middle or high school coming to us for attention issues. I think we are leaning more and more to getting an MRI, at least to rule out or to confirm a brain malformation, right? It helps you achieve a diagnosis. And what if a malformation is seen, which is non-specific brain findings can sometimes trigger a genetic diagnosis.
Yes. So, okay, good. Thank you very much. Thank you.
Mm-hmm.
I don't see other questions in the chat, and I want to be respectful of everyone's time. Should we give people maybe 30 seconds to ask questions, and then let everyone disperse with their day? Okay, thank you very, very much, Dr. Agarwal.
Thank you, Alex. Thank you. Bye-bye.
Thank you. Thank you very much.
Thanks.
Bye.
Thanks
Bye.
for having me.